Ladies and gentlemen, please welcome Grantmakers in Health Vice President for Program and Strategy, Osula Rushing.
Welcome back. I hope you took advantage of the wealth of programming earlier this afternoon, our plenary session on climate change, health, and equity, our breakout and networking sessions, our on-demand quick takes, which are ready for you whenever you're ready for them. It is my great honor to open our final plenary of the day, a new behavioral health paradigm. Support for the session was provided by the Missouri Foundation for Health. Our esteemed speaker will be introduced by Kiana Thomason, who is President and CEO of the Health Forward Foundation in Kansas City, Missouri, and is a member of GIH's Board of Directors. Kiana, I'll turn things over to you.
Thank you, Osula, for that introduction. Good afternoon, everyone. I hope the day is treating you all well. Again, I'm Kiana Thomason, President and CEO of Health Forward Foundation, a public charity foundation in the Kansas City bi-state region. I am excited to introduce such an esteemed leader, so I'm going to get right to it. Clinical and community psychologist and healthcare innovator, Dr. Arthur C. Evans, Jr., is CEO of the American Psychological Association, the leading scientific and professional organization representing psychology in the U.S. With more than 121,000 researchers, educators, clinicians, consultants, and students as members, APA promotes and disseminates psychological knowledge to benefit society and improve lives, a mission consistent with Evans' life work. Before joining APA in March 2017, Evans spent 12 years as Commissioner of Philadelphia's Department of Behavioral Health and Intellectual Disability Services. In that post, through public health strategies, he led transformation of a $1.5 billion operation and serving a wide range of individuals with complex needs. Nimbly, he emphasized data-driven, population health, and community-based grassroots approaches to improve outcomes for people and increase system efficiency. An unconventional leader, he employs science, research, community activism, spirituality, traditional clinical care, policy, and cross-system collaborations to change the status quo. From an equity perspective, he also ensured that those with lived experiences were involved with every policy decision. His work in Philadelphia has become a national and international model with high honors, to include being recognized as an advocate for action by the White House Office of National Drug Control Policy, the American Medical Association's Dr. Nathan Davis Award for Outstanding Government Service, Visionary Leadership Award for the National Council of Behavioral Health, and was inducted into the Florida Atlantic University Alumni Hall of Fame. Also, his strong work as an advocate for social justice has led to his receiving 3 different awards named for Dr. Martin Luther King, Jr. He holds a doctorate in clinical community psychology from the University of Maryland and a master's degree in experimental psychology from Florida Atlantic University. Clearly, we are among the great and in for a treat. Dr. Evans, I'll turn it to you.
Thank you so much for that introduction. About a year ago, I bought a car. And buying a car isn't such a big deal, but what was interesting about buying the car was that I bought the car without ever having seen the car, without ever having test driven the car. My wife and I, looked and observed that, this was a whole lot better than the way we typically would have purchased a car, which would have meant going down to a car dealership, actually going to multiple car dealerships over a series of weekends, sitting in the office, waiting for the manager to come and put more pressure on us. I'm sure you all have had that experience if you bought a new car. And we kind of wondered, why hadn't we purchased our car like that previously? Well, the reason was fairly simple. We weren't in a pandemic and we weren't really forced to. And that wasn't all, because 2 months later, we actually put an offer in on a house that we had never stepped foot in a neighborhood that we had never driven through. And on reflection, we started to really think about, how did this come about? How could we have made these major life decisions in ways that we would have not even dreamt of only a few months earlier. The reality is that the pandemic, the circumstances required and demanded us to change, and we were willing to change. Now, I'm a psychologist, and we're not just as psychologists satisfied with having these great insights. We have to figure out how they apply to our lives. So I started to think about the work that I do and the demands and the challenges that we face in terms of behavioral health. And I think that there are some parallels here. It is clear that we are facing the greatest mental health crisis that we have ever faced, certainly in our lifetimes, perhaps in our nation's history, when you just look at what's happened to us over the last year or so. We started with a pandemic, and that pandemic clearly had a significant impact on people's mental health status. We saw rates of stress go up immediately after the pandemic was discovered, and that we were beginning to shut down our economy and the ways that we had done our work historically. People were very anxious. If you recall, people were very anxious, and they were fearful, and they were stressed. And then very shortly after that, we saw an economic downturn as people lost their jobs, as businesses closed. And we know from a lot of research, including my own doctoral dissertation, that whenever there are economic downturns, there is a spike in mental health needs. And then on top of that, we learned that there were certain groups that were being disproportionately impacted, that communities of color were disproportionately affected by the virus. And not only did that cause increased stress and anxiety for those groups that were at higher risk, but those communities also experienced more grief and loss, which added to the psychological burden that people were experiencing. And then on top of that, we had the summer where we had a racial reckoning as a nation. We started to really look at these issues around racial justice and especially in the aftermath of George Floyd's death. And we know from the data that those events not only affected communities of color, but they affected the entire nation. In fact, a majority of Americans reported that those events were very stressful. And then on top of all of that, we had one of the most tumultuous, perhaps the most tumultuous political season, certainly in our lifetime, in a generation. And we know again from the data that caused a lot of stress. Now, if you take all of this together, what we are seeing is a crisis like nothing we've seen before in terms of the level of stress, because what our data show, we do a Stress in America survey each year, and what our data show is that there was a spike after many years of stability in the overall stress levels in the nation, immediately after the pandemic. And it stayed, that those stress levels have stayed elevated throughout. And one of the things we know about stress is not only is acute stress can be harmful to us, to our physical health, but chronic stress, which we've experienced now for over a year, is particularly damaging. We know that, for example, over nearly 80% of Americans are saying and reporting that the pandemic has caused significant stress in their lives. We also know that the pandemic has played out in other ways on our health status. We know that about 60% of Americans are reporting that they've had unwanted weight change, about 40% saying that they've gained weight, and the average being 29 pounds during the pandemic, and about 20% saying they've had unwanted weight loss. We've seen people, 2/3 of Americans report that they are having sleep disturbances. Either they're sleeping too little or they're sleeping too much. 25% of Americans are saying that they are using alcohol intentionally to manage their stress. And we know that during the pandemic, the overdose rates, the rates of deaths for overdose have gone up. On top of all of that, what we know is that the rate of symptomatology, that is, people reporting symptoms of anxiety and depression is 3 to 4 times what it was before the pandemic. And that this phenomena of increased symptoms that people are reporting is not just a US phenomena, but it's an international phenomena. And all the data is pretty much saying the same thing. Around the world, people are experiencing much more psychological distress. And if all of that weren't enough, it's happening in the context of a mental health system that was not adequately funded, not adequately resourced to deal with the needs that we had prior to the pandemic. So we have this tremendous explosion in need. We're seeing it in all of the data. We're seeing it through anecdotes that people are observing in terms of the stressors and how people are reacting and behaving publicly. And we have a system that was not adequate for meeting the needs prior to the pandemic. And now we're faced with relying on that system to deal with the reality of this explosion, what we would call a second pandemic, a mental health pandemic in which we find ourselves today. So here's the takeaway from my talk today. I'm a psychologist, so I know that I probably have your attention for about 10 good minutes. So I want to make sure you get this point. And that is that our current approach is inadequate for the complexity, the ubiquity, and the impact that behavioral health conditions have on our population. And that we're going to have to embrace a new way of addressing these issues if we're going to have any shot at trying to address these needs. So the question is, and how do we respond? And one thing that I can tell you is doing more of the same will not get us there. I'm pretty clear of that. So if I'm going to ask you to embrace a new way of thinking, I should at least start with, well, what's the current model that we have for how we think about behavioral health conditions? And I want to suggest to you that we have what I call a black box model. And so the way the black box works is this. We create black boxes, and they could be a treatment program. It could be a private practitioner's office. It could be a residential program, but it's a treatment program, a place where you go. If you see the person over there on the left-hand side of the screen, what we expect is that when we build these programs, that people who have identifiable mental health and substance use problems will understand that they have these problems, come to us, we will diagnose them, we will figure out what's wrong, we will treat them, and then we will discharge them well. And that's the way people derive the outcomes for after their treatment. Now, I've spent my whole career, 30 years, building treatment, funding treatment, trying to improve treatment. So I am a strong believer in treatment. But I also know that there is a problem with this as the mental model for how we think about treating and addressing behavioral health conditions. And if I were with you, I would ask you this question. And I've asked this question to all kinds of audiences, to policymakers, clinicians, to journalists, to all kinds of audiences. And it's striking how quickly people pick up on what are some of the challenges with thinking about mental health issues and behavioral health issues in this way. You would probably say pretty quickly that, well, one of the first problems is that people don't come to treatment. We know that only about half of the people who have a mental health diagnosis actually show up at treatment, and only 10% of people who have substance use challenges come to treatment. So the first problem is that most of the people in our communities today who need help for these conditions are not coming to treatment. So the majority of people are not even coming to treatment. You would point out that when people leave, that they're not, quote, fixed, that this model is an acute care model for what we know are chronic conditions. And we know that people need ongoing help. It's more like treating diabetes than treating a broke leg when you have behavioral health conditions. you would point out that it's a box and that it's acontextual, that we know from all of our work in the field that context matters and how people recover and where they recover matters. And these boxes are the same, whether you're in Anchorage, Alaska, Tupelo, Mississippi, or Los Angeles. And we know that those are very different environments, and they really require different ways of recovering. If we had time, we could spend the next 30 minutes critiquing all of the challenges that are presented by having a model like this. But let me tell you what the biggest problem is, and that is it constrains how we think about these issues. Because what it does is it reinforces this idea that if people have a behavioral health challenge, that the only way that we can help people is through treatment. And as I said, I'm a big believer in treatment, but I don't believe that that's the only way that we can help people. And so what I want to talk about is how can we expand beyond treatment to think about how we meet the needs, particularly right now, how we meet the needs of the nation by changing our paradigm. So let me start with building the case for this. So what you see here is a depiction of the population. If you divided the population in terms of the people who have a diagnosable condition and those who don't, about 25% of the population has a diagnosable condition, 75% doesn't. The way our healthcare system works, it's a fee-for-service system that pays only when people have a diagnosis. If people don't have a diagnosis, we don't have resources to intervene on and to help people. Now, there are a lot of problems with that model. Not only are, as we just pointed out, that many of the people who are above the diagnostic line not getting help and services for a whole variety of reasons, stigma, people don't know how to access services, people don't have insurance. We have lots of reasons why people are not getting help when they need it. But here's the other problem. That 75% are people who may not meet diagnostic criteria, but may have what we would consider subclinical issues and conditions. And furthermore, this way of thinking sets mental health up as a binary variable, that either we have a mental health challenge or we don't. And we know that our mental health status, like our health status, is on a continuum. And that over the course of our lives, we're moving up and down that continuum. And what the data show right now is that many of us are towards the deep end of that continuum. Many of us have crossed over. And what we know from the data and from past experiences is that in the next several weeks and months, that many people are across that line. But because the system waits until people come to us, or waits until people have a diagnosis, we've missed the opportunity for early intervention. So the first problem that I want to point out is that we have a large proportion of the population that could benefit from support, from intervention, where we could prevent and intervene early, but we don't have the resources because we have a fee-for-service system that only pays for sickness. But here's a second problem. If you look at what causes and leads to our health status, it turns out that healthcare accounts for a very small percentage of the variance in our health status. If you look at this chart of those factors, you can see that our lifestyle issues, what we do, our behaviors, where we live, our environment, even our human biology have a much greater impact on our health status than healthcare, even though as a nation, we're going to spend this year somewhere around 3.5 trillion with a T dollars on healthcare, and often ignoring these other factors that play a much greater role in how healthy we are. And when it comes to behavioral health, we're almost exclusively ignoring, we're almost doing that to the exclusion of these issues very routinely. And a lot of these factors we talk about as social determinants. Now, the research is pretty clear in this area that we know, we have the data to show that these kinds of things like education, income, housing, food insecurity play a big role in our health status, and they play a big role in our mental health status. And so the question for us is, how do we begin bringing what we know from the science and the data into our strategies for how we work with people? So what I hope I've done up to this point is I hope I've made the case that we have a tremendous problem on our hand. We have a model for dealing with that is completely inadequate for the level of complexity and the magnitude of the need, that there are some different ways of thinking, both in terms of who do we work with and what are the things we focus on that might help us in terms of better addressing the needs of people with behavioral health conditions. So I want to argue that it is imperative for us to move to a population health approach. So let me tell you what I mean by population health, because if you Google the term, you're going to get a lot of different ideas about what population health is. But let me tell you what I mean by population health. If we were to take that diagram of the population that we had divided between people who had a diagnosis and don't, and we divided it a little differently and divided it roughly into three broad categories of people who have a diagnosable condition, people who are at risk, and then people who are relatively healthy. Our goals as a society and as behavioral health systems would look like this. For the folks who have a diagnosis, what we want to do is to make sure that we have effective and efficient clinical care. Now, this is really important to emphasize because whenever we talk about population health or public health strategies, what many people who are in the field will hear is we're turning away from people who have a diagnosis. Nothing could be further from the truth, because if you're doing a population health approach, that means that everyone in the population, including those who have a diagnosis, are a part of that. And our goal should be to make sure that the care that they get is the most effective and the most efficient. And in the absence of that, we don't have, in my view, a true population health approach. But our work doesn't stop there, because we just talked about the problems with only focusing on people after they have a diagnosis. But in a population health approach, we start to look at who are the people who are at greatest risk. Because historically, what we do is we wait for those people who are at greatest risk until they are often in crisis before we intervene. But we could do more. We could mitigate risk, or we could intervene at the earliest possible moment. Now, we know who these people are in our communities who are at greater risk. And if I were there with you today and I asked you that question, in about 10 minutes, we could have a pretty good list of the people in our communities who are at greatest risk for developing a behavioral health condition. You would point out that people who've experienced trauma would be at greater risk. You would point out that people who are homeless, children who've been abused and neglected. You would point out that if people have a genetic predisposition, they would be at greater risk. You would point out that frontline healthcare workers are at greater risk. And we know that from what we've been seeing coming out of the pandemic. So we would come up with a list pretty quickly of who those individuals are. And then the question for us is, what can we do before people are in crisis that can help them? And then the last point here is, what about people who are okay? They're not in a high risk category. They don't have a condition. Are there things that we can do to help keep people healthy? And the answer to that is absolutely. We know from psychological research, what are some of the correlates of good psychological health? We know what the correlates of bad psychological health are. And by addressing those kinds of issues, we have a much better shot at keeping people psychologically healthy. So that's what a population health approach is. And then the question for many people is, and I've been talking about this for a number of years, I've never heard anyone say, oh, no, we don't want to work upstream. I've never heard anyone say we shouldn't do prevention or early intervention. What I do hear people say is, yeah, well, that's great. It's a great concept, but we can't really do that. Or, how can we do that? Well, I'm glad you asked that question, because we actually can. And what I want to spend the rest of my presentation doing is giving you some examples. And I'm going to pull from the work that I did in Philadelphia prior to coming to the American Psychological Association, because it's a community that had embraced this idea of population health. And we were literally working at all levels of this pyramid. And I want to give you concrete examples, because not only does this make sense conceptually, but it can be very effective practically. So let's start at the top of the pyramid and talk about how do we improve clinical care for people. So one of the most important things that we can do is to use the science to help improve outcomes. There is about a 17-year gap between what we know from research and science and what's actually widely practiced. And so when I was commissioner of the Philadelphia system, one of the things we did was we created an evidence-based practice and innovation center. And the idea was to get as much of the system using the best available science to drive and shape how we deliver treatment services. And I'm going to give you one example of why that's important. So one of the levels of care was a program or a level of care called extended acute inpatient units. These were units for individuals who were experiencing a very difficult course of treatment. They had gone to a regular acute care hospital, and after about a week or 2 weeks, it was clear that they weren't going to get better. And so we created these programs for people who historically would have gone to a state hospital, but so that we could treat them in a community. But what happened over time is that the length of stay started to get longer and longer, because we weren't able to, those programs weren't able to effectively treat these individuals. And so working with Aaron Beck and his group at University of Pennsylvania, we implemented a technique called recovery-oriented cognitive therapy. As most people know, that Aaron Beck has demonstrated, and many other people have demonstrated, the effectiveness of CBT as a evidence-based practices. And we married that with a recovery orientation. So what happens when we do that? And I should say that the length of stay, again, we're up to a year sometimes for people who were having a really, really difficult time. Well, here's what happened when we use a milieu approach, trained everyone in that evidence-based approach. We cut the length of stay in half. We reduced assaults. We reduced the use of restraints and seclusion. We reduced the need for IM medication. And really importantly, we were able to step people down into the community to lower levels of care and allow people to be serviced in the least restrictive setting for the conditions that they had, greatly improving, again, their outcomes. So just by bringing and systematically introducing science-based strategies, we're able to improve the quality of care. And I should say that this was a very diverse group of individuals. And so one of the challenges that we have often talk about is the importance of reducing disparities. And one of the ways that we can do that is by using the science to help us. One last point. These programs cost on the average of $600 to $700 a day. And so not only did we get better outcomes, but we saved a lot of money. What about addressing social determinants? We know, you ask the typical mental health professional and say, of course, social determinants make a difference. But the question is, how do we address them in our work in a systematic way? And so let's take the issue of homelessness. And we know having a home makes a big difference. And by the way, in doing this work that we did on homelessness, we discovered the key to solving the problem of people being homeless who have serious mental illnesses and serious addictions. So I want you to kind of lean into your screen because I'm going to tell you the solution to the homelessness problem in the country, particularly for people who have behavioral health conditions. It is to help people get homes. Thank you. It is true that treatment for people who have serious behavioral health conditions who are homeless is important and can be very important to helping to end homelessness. But what we know is that simply providing treatment, that black box idea that what we're going to do is we're going to get people off of the streets, we're going to run them through treatment, and once they're well, then we're going to move them into housing. We know for a fact that that model does not work for most people for a whole host of reasons that we don't have time to go into now. Suffice it to say that when we address the real issue, which is not having a home, we can greatly improve outcomes. And so when I was in the city, one of the things that we did is we started to step back and ask a question about what is the best way to serve people who are homeless. One is to create multiple pathways, because there is no one size that fits all. To use the research, available research. So we know, for example, that Housing First, getting people directly off the streets into housing, is a very effective way, particularly for people who have very serious mental illnesses, to get them stable and to improve their outcomes. But here's the real ingredient. What I think the active ingredient to this work is partnering with the Housing Authority. Our mayor negotiated 200 Section 8 vouchers that we then leveraged with Medicaid dollars for the services, and which allowed anyone who we were working with clinically to be guaranteed that they would have housing at the end of that process, or in the case of Housing First, before that process. It made all the difference in the world. And so over the course of an 8-year period, we were able to get over 1,000 people who were chronically homeless. And when we say chronically homeless, we're talking about people who've been on the streets for 5, 10, up to 15 years. So these are people that often communities have given up on. And one of the things that this has taught me is that we should never give up on anyone. It is up to us to change how we approach these complex problems in order to make sure that people do have a real shot. So when you looked at out a year, 89% of those individuals were still living successfully in their housing. But here, let me share with you some other data. I mentioned that we had different cohorts or different pathways, and each one of these groupings is a different pathway. And if you take to the very far left, that grouping, which is called Safe Havens, you see multi-year data. The first blue line that you see, or first blue column that you see where it says $85, is how much it was costing the service system 2 years before people were housed. Look what happens when people are engaged. The costs start to go up. So year two, the first year that we engage people, the costs go up to $97 a day. They go up to $112 a day. And then look what happens in the year that people are housed. The costs go down to $18 a day. So not only were we able to address a significant social problem, improve the clinical outcomes and the life of people, helping people to improve their life, but we were also able to, as one of my colleagues at University of Pennsylvania would say, we were also able to save a boatload of money doing it. What about health equity? So the chart, the graph that you're looking at here is of data called penetration data. Penetration data is basically the proportion of a population that is accessing the behavioral health benefit. So if you have Blue Cross Blue Shield, about 3 to 5% of Blue Cross Blue Shield recipients access behavioral health care, the behavioral health care benefit. In the Medicaid population, we were managing that benefit for Medicaid recipients in Philadelphia. We were at about 20%, and that number was going up every successive year on average. And so this data looks really good, right? Except that if you disaggregate the data, you get a very different picture. You'll see that for whites and Hispanics, that the penetration rate was quite good. African Americans, it was half of that. And for Asian Americans, it was half of that. So disaggregating the data so that we can see what's happening in different populations is really critical. But we can't stop there with just noting that there is a difference. Then the question is, what do we do about it? So I'm going to explain to you the four maps that you see here, or the three maps that you see here on the screen. This was done by some colleagues at University of Pennsylvania, who Eileen Rothbard and her group. And essentially, these three maps tell us one thing. Areas of low utilization. This is a map of Philadelphia. And she mapped areas of low utilization. We found that those areas where we had low utilization, given the population, that those were disproportionately African-American communities. And then the last map there shows that one of the things that explains the low utilization was that there were fewer providers in those communities than were needed for the numbers of people in those communities. So what we found is that, using the data, is that we had a structural problem. All of the cultural competency training in the world would not have helped if we didn't understand that we had a structural problem that we had to deal with. So what we did is to do an RFP for those specific areas in the community for culturally competent care, but we were able to address the structural problem by focusing in and using the data. And so addressing those health equity issues is another really important aspect to improving clinical care. So let's talk about, and I've made the point that effective and efficient clinical care is one thing, but we want to expand beyond that. And so the question is, if you were in your community, if you were responsible in your community, your city, wherever you're living now, for addressing the issues of people who are at greater risk, what kinds of things would you do? Well, I'm glad you asked that question as well. So let's take a look at a few things. So one of the key concepts when we talk about risk is for us to work further upstream, not waiting for people to come to us, but getting out to people, identifying people early in the process. One of the ways we did that in Philadelphia was to screen children for behavioral health conditions. What you see here is a map of the city. The dots that you see are evidence-based treatment programs for the treatment of trauma in children. I told you that we were very systematic in putting these programs all over the city. And so when children were screened for trauma, those who screened positively were then referred to these evidence-based treatments. It's one of the things that I felt the most proud of in my career, because we know that children, through the ACEs studies and other studies, who experience early childhood traumas have a much different life trajectory. And the fact that we were able to identify these children early and then to intervene early, really, I believe, will change their life trajectory, prevent them from experiencing a lot of stressors and other challenges that people have when they have untreated traumatic stress in their lives. So that's one way that we can get to these children. And I should say about 30% of these children screen positively. So it's a pretty significant number of children who screen positively in pediatric settings like primary care settings and so forth. Another way of trying to get upstream is to not wait for people who've experienced trauma to develop PTSD or other psychological symptoms, but to get into communities in the immediate aftermath. And we did this by training people in psychological first aid, which is a trauma treatment or a trauma intervention that is done in the aftermath of hurricanes and so forth. But training people to go into communities after any kind of traumatic event. It could be a shooting, it could be a building collapse, it could be any number of things. And so over time, anytime there's a trauma in the community, there is also a behavioral health response. And the idea is to help people understand what a normal or typical trauma response is and what's atypical, and how to get help when you're experiencing atypical response to a traumatic event. So trying to get to people much earlier. And I will say that one of the great insights that we had as we were doing our trauma work is to start to think about trauma from a public health standpoint. And so there were multiple kinds of ways that the community started to create, one of them being, rather than sending trained professionals into communities, sending community members who've been trained in some of these techniques into the community. So it was neighbors helping neighbors. Okay, how about early intervention? How do we intervene early? So one of the groups, and this is an example from the American Psychological Association, we're very committed to working with rural and frontier communities. These are communities that have historically been underserved when it comes to mental health needs. And so we're partnering with groups like Farm Aid and other groups. And one of the things that we discovered early on, or were advised, was that one of the ways that we could be most helpful is to help the people who are helping farmers in particular who are in crisis. Many people in this country don't know that we are experiencing a farm crisis in this country, that many farmers, family farmers, are losing their farms, farms that have been in their families for generations. And the stress and distress that causes is very significant. Often people will reach out to hotlines to help get loans or other kinds of financial help. And what we're finding is that if we can help those individuals who are on the other end identify and help connect people to resources, that could be a really important pathway for people to get help. And so those kinds of strategies of, again, not waiting for people to show up in crisis, but embedding mental health professionals in the places that people are already going and the places and the resources that people already trust is a very effective strategy for getting to people much earlier in their process. Creating psychologically healthy work environments and other environments is another strategy. One of the ways we did that for healthcare professionals is to create self-help techniques or strategies that people who are frontline healthcare workers could use to help manage and mitigate the stress that they were experiencing on a shift. And so what we did was to give people, based on psychological research, here are things that you can do to mitigate the stress that you might be experiencing on a shift. And then we also told them, here's the science behind why it works. And I think if you look in your chat, there will be a link for that if you're interested in that. But it's built on this principle of behavioral health activation. We talk about health activation, that there are things that we can all do to protect ourselves or to improve our health status. And one of the strategies for reducing risk in communities is to help empower people with the knowledge to better manage their own mental health status. Similarly, working with organizations to help them create psychologically healthy workplaces. We have a psychologically healthy workplace award that we give each year, and resources to help employers do to look at things that they can do to make their environments more psychologically supportive. And one of our strategies is to work with a whole variety of groups to do that. And then finally, one other strategy that I want to give as an example is the importance of reframing behavioral health as a strategy for reducing risk. So one of the groups that we focused on is men of color, African-American men, Asian men, and Latinx men. And one of the things we wanted to do is to see if we could reframe the issue of mental health, because there's so much stigma associated with the topic. Men in general typically don't like to talk about having mental health challenges. And so one of the things we decided early on is, what if we reframe the issue? Instead of talking about mental health or mental illness, if we talked about mental wellness or mental strength or psychological strength. And the way we did that is partnering with a community storytelling group called First Person Arts. And the whole idea was to get men to tell their story about their own psychological health. Now, when we first did this, we were like, not sure if men are going to do this. And what we found is that men actually would do that. Bus drivers, teachers, lawyers, all kinds of men would do that. And we would pair them with a well-known person. People you see on these flyers here are the well-known people. People would tell their stories. And it was striking to us that on a Friday night, the first time we did it, we weren't sure. Now, first, we weren't sure if people would do this. Turned out they would. But then we weren't sure that there would be an audience for hearing men talk about this and then have this interaction with the audience after their presentations. But the first time we did, we had 300 people. The venue was filled up. Next time we did it was 600 people on a Friday night, Philadelphia, talking about men's mental health. The next time we did it, there were 1,000 people. And this one was for adolescents talking about their own psychological health. So what it told us was that this is a conversation that people are hungry for and people want to have, and that it's important for us to create environments for that to happen. So finally, let me talk a little bit about how do we keep people healthy. And I'm going to just give you, again, a couple of examples. This group that you're looking at is the Burmese and Bhutanese communities. And this is an immigrant group that is not going to walk into our black boxes. So for as much as there might be needs in these communities, they're just typically not going to come to the traditional community mental health center for the most part. I believe that inherent in every community is the wisdom to solve its own problems. And so the way we approach these communities is to not go to them and say, we have this program over here, you have needs in your communities, come to our programs. We go to people and we ask them, how do you understand your problems? How do you understand the solutions? And when you ask people that, it's really interesting. They come up with really great solutions. And one of the ways that we work with these communities in these types of communities in Philadelphia was to create coalitions of people, of providers and well-trusted members of the community. And in their case, they said, let's embed a mental health professional in the places that members of our community go. So where people go for English as second language help or immigration help. And when we did that, what we were able to do is identify a lot of people who would not have traditionally been identified and either address their issues in that context or to refer them to culturally appropriate treatment. Normalizing mental health. So one of the other strategies, if we want to really help people, is to begin changing how the community sees these issues. One way of doing that is just by simply showing up in places in the community where people go. Started doing community mental health screenings. So first started doing this, people said, people will never walk up in Philadelphia to a table that is talking about mental health. Turns out that actually lots of people do. And these are people who are not going to come to a traditional mental health clinic, but if you're in the community, and we started to do this in parks and train stations and libraries and coffee shops and all kinds of places, people came up. Sometimes we would screen as many as 100 people at a time. Almost every time we did it, there was at least one person who was suicidal at the time that we did these screenings. And I always think about, what if we weren't in the community that day? And what is happening in every community where we're not in the community because we're in our black boxes waiting for people to show up? What we know is that when we are out there, people want to have those conversations. They want to get that information, and they often want help. The last example is this. The biggest challenge I think that we have, or one of the biggest challenges, is reducing the stigma around these issues. How do you have these kinds of conversations in communities? It is very difficult. I would often joke that if we were to go to a community and say, hi, we're from the government. We want to talk to you about mental health. About 5 people would show up and we would be related to about 3 of them. It's not the kind of conversation that we can often get people to do. And so I was fortunate early in my tenure to hear about the city's mural arts programs. Philadelphia has more murals than any place in the country, any urban city in the country. This mural that you're looking at is one that we worked on. This picture is taken from a mile away. So it gives you a sense of the scope of these. These murals are actually painted by the community. So when I heard the description of the process of communities coming together to talk about a particular issue, working with an artist, coming up with a concept, and then painting it, I talked to the director of the program, Jane Golden, who was open to the idea of having some of those conversations that communities were having be about mental health issues. And it started a partnership that continues today. And what it allowed was for us to have conversations about issues like children's resilience in a non-threatening way, like this is what that particular mural looks like. Or in the Latinx community, this is a mural that is focused on some of the stressors related to immigration for members of that community. Or this is a mural that was worked on over the course of a year, a series of workshops and other kinds of psychoeducational events around suicide. Over 1,000 people worked on this. And these were conversations. These were both people who were suicide survivors and their family members, and people who had died by suicide, their family members. These were conversations that we would have never happened or would have been less likely for us to happen had we not used this strategy of using community art as a way of doing it. This is just one more mural that was worked on by over 1,000 people. So here's where we find ourselves. We have lots of major issues, and I hope what I've done during this talk is to demonstrate that there are ways that we can work differently and reach people that we would historically we've not reached before, to improve the outcomes of treatment, and that we can expand this treatment black box metaphor. As I said, treatment is important, and there are lots of ways that we can make it better, but we can't stop there. We really have to think about the whole population and how we can address the needs. And I think funders are in a unique position to do that. You bring credibility, instant credibility. I didn't mention that many of the things that I've talked about today are things that were supported by foundations. For example, the mural arts work that I was telling you about, early funders were Robert Wood Johnson and the Scattergood Foundation. That support meant everything for our ability to move those really high risk, innovative kinds of initiatives forward. So funders are in a unique position to do that. And so here's my ask. I would hope that you would begin embracing this way of thinking about whole population, thinking about as you review applicants, is this more of the same, or is this work that really advances our ability to reach people that we've not reached before? And to bring your stature, credibility, people who are, like I was for many years, for 20 years, a policy person, are risk averse. And many of the things that we need to do are things that will appear to be risky to them. You, frankly, can provide some of the cover that they need in order to do that, in addition to the resources, in addition to the networking that you can help people do with other like-minded people. And then finally, I really hope that you will see APA as a resource and a partner to help you do this. We're making a commitment to this way of thinking, and we want to be a resource for you to do that. So we've changed how we shop and how we teach and how we learn and how we work. The circumstances forced us to do that. but we had a willingness to make those changes. Similarly, the circumstances in which we find ourselves for behavioral health are demanding, they're demanding that we change the paradigm. If we don't, we're going to miss so many people. We're not going to meet the needs of people that need our help. We have to expand the paradigm. And what I hope is that you will help us build the nation's willingness to make that change happen. So with that, I'm going to stop and see if folks have any questions or comments.
Arthur, thank you so much for that comprehensive presentation with so many fantastic and replicable examples for our audience. I truly appreciate it. And we see why they say you are visionary. Everyone, we have reached the almost end of our conference day. I want to thank all of you for joining us for this third day of GIH's annual conference on health philanthropy. I'm afraid you can't leave yet because I want to give you a quick preview of tomorrow's agenda. We'll reconvene at 1 o'clock Eastern Time to hear from the winners of GIH's Terrence Keenan Leadership Award in Health Philanthropy and GIH's Andy Hyman Award for Advocacy. We'll have a final round of breakout sessions at 2 o'clock Eastern and networking sessions at 3 o'clock Eastern. And then we'll close with a plenary on embedding rural issues in equitable conversations. We hope to see many of you at our social hour, which begins in a little over 15 minutes. For all others, thank you for joining us today. Have a wonderful evening, and we'll see you tomorrow.